So then if you think that this patient with high-risk features has gone through many of these novel agents, when we look at venetoclax and rituximab, given the recent MURANO data that got presented or represented with longer follow-up, actually 3-year follow-up, how do we look at that in the setting of a patient such as this with high-risk features? Now, the MURANO data was very nice because it obviously, even though it was in this exact situation of relapse refractory patients with CLL, and we looked at levels of minimal residual disease on these individual patients, and it was time-limited duration of therapy. So the venetoclax actually was only for 2 years. Now, what the data did provide is that looking at individuals based on their MRD level, that folks who had high MRD are likely to progress sooner than folks who had obviously undetectable minimal residual disease or even just low levels. And so one may be able to use that information in a patient that is high risk such as this and say, do we end it at 2 years? Should we be checking for minimal, in fact, that's what I would be doing, is we should be checking for minimal residual disease in a patient who's young with aggressive features to think about whether or not they should be stopped. And so now you can actually start really being a lot more specific about how to finesse these therapies. And even though the protocol obviously did stop individuals, so at 2 years everybody stopped regardless, it was amended to allow patients who then progressed to reintroduce venetoclax therapy. If this patient wasn't on that protocol, you might consider looking at the minimal residual disease. If they were undetectable, the question remains, do you stop therapy because they're high risk, or do you be true to what we've just presented with the MURANO data, stop therapy and wait till they relapse, okay? And I think that is one area that we still need longer term follow-up in patients who are high risk. Is it a benefit them to stop if they have undetectable levels and wait? Or should we not, because eventually we know that they'll probably relapse, and is that good enough? Will they be sensitive again because they're high risk? I think that's an area that we still need a lot more investigation and further follow-up and data on. I am currently a little nervous about stopping my 17 patients regardless. And so even if they were undetectable, I'd be happy that they're undetectable, but I would likely still continue drug. So when we look at combinations such as venetoclax or rituximab or some of the other combinations that are being explored, the reason some of these are being explored, of course, is everybody is very interested in looking at how to use a short or a time-limited duration of these therapies. So in other words, that patients won't be on ibrutinib indefinitely for the rest of their life, or on venetoclax indefinitely for the rest of their life, both for toxicity issues that might be mounting. We've been seeing if we look at some of the real-world data sets that have been presented at these meetings, that there's no doubt, and I think this is not unique to CLL, I think this has to go with many disease states, whether oncology or not oncology. Patients, it's a little bit of fatigue in terms of their medications, and there is a non-compliance issue that patients have. So all of these novel therapies are oral, and so if they're indefinite, there is a degree of non-compliance that happens over time, even for some side effects that are completely manageable but are nagging to the patient. A little diarrhea here and there can be nagging, and so they just will take less, they'll skip some pills, so I think there is an area of concern about resistance, and there's an area of how do we make this better for patients in the long run. And so looking at some of these strategies of time-limited duration of these therapies, deepen these responses, so by these combinations, really look at achieving deep responses so we can stop therapy, and then see how long they would go till their time to their next treatment. Because in chemoimmunotherapy, that's what we did. We could not continue FCR or BR indefinitely because these were intense therapies. So that you would give 6 cycles, you were done until you needed treatment again. Hopefully that wouldn't be for years down the road, but that's how it was because you couldn't just keep that going. Similarly, maybe now that we have deeper responses, particularly with the venetoclax combinations, deeper responses, that we can shorten the time period and sort of make an analogy like we did in the chemoimmunotherapy, although hopefully better, but that we can stop people and then reintroduce drug. That will also save on not just hopefully toxicity, but cost. These medications are extremely expensive, I think this is an issue. We've talked and highlighted at this meeting that there are many countries that patients don't have availability to these novel therapies, or even in the United States. I could speak to the folks in the United States. There are some patients' insurances that their copays are too large for even drugs like ibrutinib, which is now standard of care. And so I think this is going to be a problem. So if we can if we can pursue, this is sort of the future of where CLL is going towards, if we can get deep remissions, decreased toxicity, shorter durations of therapy, cheaper, then it'll be a benefit in the long run for patients.